talk is by Dr. Natasha Radhakrishnan, Professor, Amrita Institute of Medical Sciences. Over to you, madam.
Good morning, all. So we have seen all the screening, classification, and the newer terms. Now we will go to what has changed in the treatment of ROP. So the challenges are that once there was the traditional treatment that we were following for many years, and then there was a paradigm shift when the anti-VEGF was introduced into the fray. And the management options have expanded, and yet there is an absence of consensus. And one management plan may not fit all the newborns, and there is lack of long-term follow-up for the newer modalities of treatment. So the evolution of the management of ROP is from the cryo-ROP study from 86 to 96. In the 90s, everyone shifted from cryo to laser photocoagulation. Then we had the ET-ROP, the revised IC-ROP, and it was in 2008 to 2013 that the BEAT-ROP and the Rainbow studies that came out and told us that anti-VEGF could be used in ROP. So I think this has already been covered, so we will not cover this. That is the treatment criteria that is given to us by ET-ROP. Now, what are our management options? We can do laser photocoagulation, we can give intravitreal anti-VEGF agents, we can combine both, or we can observe. When do we observe? We observe type 2 ROP. There is no change in that. And this is because, why do we observe? So we'll have questions asked by the bystanders usually. When you tell them that, no, we are going to wait and we are going to observe for some time. And that is because of this, because there is such a high incidence of spontaneous regression. Most of the studies show more than 90% incidence of spontaneous regression. So you don't have to laser every stage 1 and stage 2 baby that you see. And photocoagulation, of course, though we have a defined criteria for when do we photocoagulate, we really don't have studies that compared cryo and laser photocoagulation. But everyone just shifted to laser photocoagulation over the years, and it has stood the test of time. And it continues to be the gold standard. And it can be used in combination with anti-VEGF, as we will see later. What are the advantages? We have long-term experience with it. There is reduced breakdown of the blood retinal barrier compared to cryo. There is a longer interval between treatment and retreatment if needed as compared to anti-VEGF. There are some studies have shown that neurocognitive scores are better, and it is better suited for patients with accessibility and without who have financial constraints. The disadvantages are that it gives no possibility of physiological revascularization because it ablates the avascular retina. There have been field effects that can occur later on. Exudative retinal detachments can occur, higher post-laser myopic errors, and then, of course, some amount of reactivation also. So this is what happens when we laser. You can see that the avascular retina is lasered and the vascular retina is preserved. What are the practical tips for those of you who are practicing ROP laser? You can either complete one eye first and then break and move to the next eye so that you don't have to, so that you complete one eye and then move to the other eye, or you can practice it in that, whichever position you are in, you can do nasal of that eye and temporal of the other eye in that same position. And always put saline or antibiotic drops during the procedure. Usually we use saline to maintain the clarity of the cornea. The type of laser can vary from diode to frequency doubled Nd:YAG, and usually it takes about 20 to 60 minutes and depends on the experience of the surgeon. And nearly confluent burns is the difference that we do in ROP laser when compared to diabetic retinopathy laser, where we leave at least half burn width apart. Here, our idea is to ablate the avascular retina, and any avascular retina that you leave behind will secrete VEGF and cause reactivation. So there should be no skip areas, and the entire 360-degree of the avascular retina should be covered by your laser. It's a short video. I don't think you need to play the whole thing. I'll just play a little bit. So always, preferably you do it in the NICU, or you can do it in your OT if you have anesthetic backup, because the child needs to be monitored throughout the procedure. So it is always safer for you to do it in the NICU. As our Dr. Biju Raju has done always, he shows those videos, you can actually do it through the incubator as well. But most of the time nowadays with improved neonatal care, we actually don't need to do that. They give us support and give you, expose the baby to you for the laser. Next, we come to anti-VEGF agents. So what do anti-VEGF agents do? They target the hypoxic drive that is keeping this, neovascularization alive. And it is better suited to zone 1 and AP-ROP patients, as we have found out. It reduces field defects and post-intervention myopia. There is a less than 8% recurrence rate. There is a faster regression rate compared to laser. Faster procedure, hence less stress for the child. You can see the child wailing in that laser procedure. So here it gets over in less than 2 minutes. And perioperative role has also been tried in just before surgery. Now, currently, after the BEAT ROP and RAINBOW trial, what are the indications for anti-VEGF? So you can use it as a primary therapy for zone 1 disease. You use it in aggressive ROP. You use it when there is a polydilating pupil and media haze making laser difficult. And if you have a failed laser treatment, either for retreatment or before surgery, you can use anti-VEGF. When should you avoid? If you think your baby has stage 4B and is in imminent danger of a traction detachment, do not inject at that stage because you are going to hasten the process. And any other presence of significant traction, you should not inject anti-VEGF. The studies, we will not go into the details. We have the BEAT ROP that gave us bevacizumab is as good results as laser, and RAINBOW, which gave the FDA approval for Axentrix, for ranibizumab. Now, practical tips during injection. SAFER is the acronym that we use. Use a short needle, the 32 gauge needle. Antiseptic or antibiotic betadine should be put prior and after the procedure. Follow up 2 to 7 days after injection to look for injection related complications and to look for regression. And always maintain complete asepsis. If possible, you can shift to your OT, but most of the time these babies are extremely sick and cannot be shifted out from the NICU. You have to tell the NICU staff how important it is to maintain asepsis just prior to the procedure, and use the recently fumigated room in the NICU for the procedure. And ideally, you should do 2 eyes in 2 sittings and not in the same sitting. And the injection site is usually 1 millimeter posterior to the limbus in these children, and about 0.025 ml is injected. And yeah, what complications can you produce? You can produce a lens touch cataract if you have not directed your needle correctly. You can produce a hyphema or a vitreous hemorrhage. Tangential traction sometimes causes macular hole formation. RP changes at the macula have been recorded, and choroidal ruptures have also been reported post anti-VEGF injection. Now, what are our controversies? We do not have long-term experience with anti-VEGF, and some physiological angiogenesis is also inhibited by the anti-VEGF. Ideal dose is still under trial, we really don't know. Ideal time for administration also, you should do it when the ocular VEGF levels are high, but you cannot do it as prophylactic treatment, so the ideal time for intervention is also still controversial. And why can we not use anti-VEGF monotherapy? So anti-VEGF monotherapy, there is a late recurrence and need for frequent follow-up. All of us who have injected know that once you have injected, the eye just goes into some kind of a dormant state. And then the normal vascularization to proceed takes a long time, which means where you actually finished your laser follow-up babies by 40 weeks, you can send them off and then call them back at 3 months. Here you have to follow up these babies weekly or 2 weekly till they are 54 or 56 weeks, which means such a big baby that I always joke to the sister, this one is ready to go to play school. So that late you will have to follow up because there is late recurrence and late persistent avascular retina. And crunch phenomenon can occur because there is pre-existing fibrosis, which you would have seen as vascularity, and then that whole thing crumples and produces a peripapillary contraction. Risk factors for recurrence are again the same, those who have aggressive ROP, immaturity, and cumulative health issues. So then came the concept of combination therapy. Why don't we give both? Give anti-VEGF and then give laser. And there is a possible synergistic effect of the rapid blocking action of VEGF by the anti-VEGF agents and suppression of further production by the laser ablation. And 94% of zone 1 ROP had a favorable structural outcome when this was followed. And it was published by Dr. Parveen Sen, who was here in the hall earlier. And you can use anti-VEGF in combination with surgery as well. Surgical treatment I will not go into because it's going to be covered by Dr. Parag. Now finally, what do I follow in my practice? So the IROP group came to a consensus that you can do combination treatment which will avoid this long follow-up for these babies. So zone 1 and zone 2 posterior I inject, followed by observation. I am observing for whether there is a reactivation and whether the vascularity is proceeding into zone 2. And what do I inject between Avastin, ranibizumab and aflibercept? Although we have the BEAT ROP study, after the PGI Chandigarh problem with the Avastin, it is always preferable for you to inject Axenrix because now we have FDA approval. Axenrix, sorry, I have no financial interest. Ranibizumab because that is having the FDA approval. Aflibercept also some of the doctors are injecting, but again we do not have FDA approval for ROP. Now, advantages are that the longer follow-up can be avoided and you don't have to worry about late recurrence, and you're giving the chance for full vascularization of at least the posterior pole, and it adds to the treatment cost of the baby. Once zone 2 is like mid-covered or at least reaching up to mid-zone 2, then I laser the baby, which usually takes about 4 to 6 weeks. And if reactivation occurs before that, you laser prior. If it does not occur, then by 4 to 6 weeks after your injection, you can laser off the rest of the avascular retina. Again, I use the double frequency Nd:YAG in a single sitting. Then on, you can follow up 1 week, then 2 weeks, and you can actually give 6 months follow-up, and the babies do just as well as your lasered babies. This is a refractive error study that we did recently with the different study groups in 4 years. We have found that injection and injection plus laser actually there is an incidence of more myopia than laser alone. So we have not done away with that long-term sequelae of myopia with injection. This first block is just monotherapy injection, which I was doing long back in 2015 when the anti-VEGF started. And those babies are also developing myopia. So you need to do long-term follow-up, whether you have injected or lasered. If your baby has ROP, you need to do long-term follow-up. That has also been covered by Dr. Sheera earlier. So I'll stop with that. Thank you for your patient listening.
Thank you, madam, for the excellent talk and the excellent work madam is doing at Amida Institute.